Everyone, please remain standing as this is the time for lighting of the traditional oil lamp, which is a timeless symbol of purity, enlightenment. May its gentle glow guide us toward greater compassion and service.
We now invite our distinguished guests to proceed to the lighting of the oil lamp. The chief guest, Vidya Jyoti, Senior Professor, Prasad Katulanda, Consultant Endocrinologist and Diabetologist, Professor and Head of the Department of Clinical Medicine, Faculty of Medicine, University of Colombo. Guest of Honor, Dr. K.D.S.N. Yasavadana, Senior Consultant ENT Surgeon, Lady Ridgeway Hospital for Children. Orator of today's inaugural academic session, Professor Sisira Siribadana, Chair Professor of Medicine and Honorary Consultant Physician, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. President of Anuradhapura Medical Association, Dr. Priyankika Gamage, Consultant ENT and Head and Neck Surgeon. President-elect of Anuradhapura Medical Association, Professor Anjana Silva, Chair Professor and Head of the Department of Parasitology, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. Vice President, Dr. Hemal Senanayaka, Consultant Physician and Senior Lecturer, Department of Medicine, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. Joint Secretary, Dr. Vatsala Gunasekara, Consultant Vitreoretinal Surgeon. Joint Secretary, Dr. Anuradha Jayatilaka, Consultant General Surgeon and Senior Lecturer, Department of Surgery, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. Assistant Secretary, Dr. Vishaka Kerner, Consultant Anesthesiologist. Social Secretaries, Dr. Dhammika Senaviratna, Consultant Transfusion Physician, and Dr. Vasana Mendes, Consultant Hematologist, and Head of the Department of Pathology, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka.
Treasurer, Dr. Chintaka De Silva, Consultant Gastroenterologist. Assistant Treasurer, Dr. Tharanga Fernando, Consultant Cardiologist. Joint Editor, Professor Kosala Veerakorn, Professor in Parasitology, Department of Parasitology, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. CME Coordinator, Dr. Udaya De Silva, Consultant Pediatrician. Representing the Council members, Dr. Prasanna Veeravansa, Consultant Physician and Senior Lecturer, Department of Medicine, Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. Dr. Champa Alukweera, Provincial Director of Health, North Central Province. Dr. Nimala Aryaratna, Director of Teaching Hospital, Anuradhapura. Dr. Janaka Pushpakumara, the Acting Vice Chancellor and the Dean of Faculty of Medicine and Allied Sciences, Rajarati University of Sri Lanka. Dr. Manjula Kaldera, Consultant Neurologist and the President of the Medical Specialists Forum of Teaching Hospital, Anuradhapura. Representing resource persons for the academic sessions, Dr. Andreas Kutsumpas, Consultant Gastroenterologist and Interventional Endoscopist, Lycon University Hospital, Athens, Greece.
Thank you, ladies and gentlemen. Please remain standing as we now honor our beloved motherland with the singing of the national anthem.
Sri Lanka Mata, Upper Sri Lanka, Namo Namo.
Thank you, honored guests. We invite you all to take your seats. Before we proceed, may I kindly invite our distinguished dignitaries to the head table. I would like to invite President of Anuradhapura Medical Association, Dr. Priyangika Gamage, Chief Guest, Vidya Jyoti, Senior Professor Prasad Katulanda, Guest of Honor, Dr. A.D.K.S. Sanyasawardana, Orator, Professor Sisira Siribaddana, Joint Secretaries of Anuradhapura Medical Association, Dr. Vatsala Gunasekara and Dr. Anuradha Jayatilaka. Please take your seats at the head table.
To formally welcome you all and to deliver the presidential address, it is now my honor to invite the founder president of Anuradhapura Medical Association, Dr. Priyangika Gamage.
Good evening. Professor Prasad Katulanda, our chief guest. Dr. Samanya Savardhana, our guest of honor. Professor Sisira Siribaddana, our today's orator. Dear council members, respected members of Anuradhapura Medical Association, distinguished guests, dear colleagues and friends. It is with great pride and deep sense of responsibility that I welcome all of you to the inaugural ceremony of the annual academic sessions of Anuradhapura Medical Association. This gathering is not merely an academic event. It is a celebration of our dedication to the health and well-being of the people of the North Central Province and the nation as a whole. Anuradhapura, with its rich cultural heritage and its unique health challenges, continues to remind us of the vital role the medical profession plays in shaping the lives of our communities. From chronic kidney disease to maternal health, from non-communicable diseases to the ever-evolving threats of infectious diseases, our region requires a medical community that is both scientifically competent and deeply compassionate. I am proud to say that the members of our association continue to exemplify these qualities each day. This year's theme, Rooted in Heritage, Advancing Through Science, reflect our commitment to embracing scientific advancement while remaining grounded in the realities of our local healthcare landscape. We recognize that medicine today demands not only clinical excellence, but also innovation, interdisciplinary collaboration, and a willingness to adapt to rapidly changing circumstances. Our annual academic sessions provide a valuable platform for the exchange of knowledge, experience, and ideas. Tomorrow, we will hear from experts, researchers, and clinicians whose work inspires us and challenges us to push the boundaries of our understanding. I encourage each of you to participate actively, ask questions, share insights, and build networks that will strengthen our medical community long after these sessions conclude. I wish to take a moment to thank all those who have worked tirelessly to make this event possible. Special thanks go to my secretaries, Dr. Vatsala Gunasekara, Dr. Anuradhapura, and Dr. Vishaka Kerner, and my Vice President, Dr. Hemal Senanayaka. And one name I have to mention, she is known to all of us, my guide and who has been traveling through this journey with me in thick and thin, Dr. Dhammika Senaviratna. And so many friends who were behind me in this journey. Even though I have not mentioned their names here, I will always cherish them with gratitude. The organizing committee, the scientific committee, our sponsors, and our partners have invested immense time and effort to ensure that this year's sessions uphold the high standards we have come to expect. Your dedication is truly commendable. To our invited speakers and guests who have traveled from far and thank you for honoring us with your presence and your expertise. Your contributions enrich the knowledge base of our association and inspire us to strive for excellence. I believe it is important to briefly highlight why our organization was formed, especially as the founder president of Anuradhapura Medical Association. It was the collective dream of many of us to elevate the academic culture of Anuradhapura to the next level. With this vision, those of us who are here today, along with few colleagues who now work in other stations, came together to establish the Anuradhapura Medical Association. As consultants and mentors, it is our responsibility to guide our junior doctors, support their continuous education, and equip them with new knowledge every day. Medical science evolves rapidly. New discoveries and advancements emerge constantly to improve patient care. Therefore, it is not only doctors who must stay informed. Our nurses, paramedical staff, and even the general public must also be aware and engaged. With this broad mission in mind, we began our journey. Forming Anuradhapura Medical Association was a tremendous challenge. Some hurdles were emotionally difficult. Yet, at every step, my council members and consultant colleagues stood beside me, safeguarding and supporting me. I am deeply grateful to each one of you for believing in me and for standing by me throughout these challenges. Despite the obstacles, together, we achieved an extraordinary amount of academic work, including 14 mega regional sessions conducted with 14 respected colleges. I extend my heartfelt gratitude to all who so generously supported us. I also wish to thank all my consultant colleagues, whether present here or not, for organizing these events and creating a vibrant and inspiring academic year for all of us. In addition, we proudly launched our journal, Journal of Tropical Health, made possible through the dedication of my dear colleagues Anjana and Kosala, guided by our esteemed orator today, Professor Sisira Siribaddana. In closing, let us reaffirm our mission to promote scientific inquiry, uphold ethical medical practice, and foster a professional environment where learning and service go hand in hand. Let us continue to be the voice of our patients, advocates for better healthcare policies, and leaders in shaping a healthier future for our communities. I extend my warmest wishes for a successful, productive, and inspiring set of academic sessions. May this gathering strengthen our unity, broaden our horizons, and motivate us to continue serving with empathy, integrity, and unwavering commitment. Thank you. And may the annual academic sessions of Anuradhapura Medical Association be declared open. Thank you.
Thank you, Madam, for your inspiring words. As we celebrate this year's journey, we will now take a moment to revisit the highlights of our academic year, the events, accomplishments, and moments that brought us together as a community.
From the sacred city of Anuradhapura, where wisdom and kindness unite,
We stand as one with purpose and vision.
to serve, to teach, to guide the light. We are with hearts that care, spreading love and hope everywhere, through knowledge and service, hand in hand. We heal and uplift our land.
Am I the strength of our region?
An academic home so true. We share, we learn, we grow together in everything noble we do. We are Emma with hearts that care, spreading love and hope everywhere. Through learning and sharing, we stand tall. Anuradhapura, we serve all.
We nurture dreams and shape each career.
Support every team through joy and tears. With charity, wisdom, and love as our art, we heal with hands and touch each heart. We are Emma with hearts that care, bound by love beyond compare, together in service.
every moment we just witnessed stands a team whose dedication made these milestones possible. We extend our heartfelt thanks to each of them. At this moment, I respectfully invite President of Anuradhapura Medical Association, Dr. Priyangika Gamage, to return to the podium to introduce our distinguished guest of honor and to graciously present the citation.
It is my great pleasure to introduce our esteemed guest of honor, Dr. A.D.K.S.N. Yasavardhana, who has been my teacher, my mentor, my guide. Dr. Yasavardhana is a highly respected consultant ENT surgeon at the Lady Ridgeway Hospital for Children, a position he had held since 2001. In addition to his extensive clinical work, he holds a vital leadership role in postgraduate education as the chairman of the Board of Study in ENT Surgery at the Postgraduate Institute of Medicine. He has also provided significant national leadership to the medical community, serving as the immediate past president of the Association of Medical Specialists. Dr. Yasavardhana's main interests lie in pediatric ENT surgery with a special focus on pediatric airway surgery, childhood deafness, and cochlear implantation. Ladies and gentlemen, please join me in giving a warm welcome to our guest of honor, Dr. A.D.K.S.N. Yasavardhana. Over to you, sir.
Thank you, Madam President, for your kind introduction. So, President and the Council members of the Anuradhapura Medical Association, our chief guest today, Vidya Jyoti Professor Prasad Katulanda, orator today, Professor Sisiri Siribadana, members of the head table, members of the Anuradhapura Medical Association, distinguished invitees, ladies and gentlemen. Let me first thank the President and the Council of the Anuradhapura Medical Association for inviting me as your guest of honor. I am truly honored and absolutely delighted for your kind invitation. I can very well remember visiting Anuradhapura Hospital, that was actually General Hospital Anuradhapura in the early 90s. Though at that time the Anuradhapura Hospital catered for a very large number of patients who came from Anuradhapura from faraway places and even received war casualties during that time, only major specialties and few subspecialties were available with considerable shortage of both medical and specialist medical officers. However, those who worked at that time worked very hard with extreme dedication and commitment. Later, I had to visit Anuradhapura Teaching Hospital a few years ago to approve and recognize the ENT department of the Anuradhapura Hospital for postgraduate training. There I realized that the hospital has expanded tremendously with many super specialty departments and was providing health care to level of tertiary care hospital. I met very capable, dedicated and relatively young set of consultants who are providing excellent service to whole of the North Central province and beyond. Moreover, Rajarata Medical Faculty has been established during this time, adding a different dimension to Anuradhapura Teaching Hospital. Medical school has attracted many very good academics. Hospital has established new departments and has acquired new state-of-the-art medical equipment. Then there were batches of medical students who were learning the art and science of medicine in many wards. These were, of course, a welcoming sight and experience for any medical professional. In my own specialty of ENT surgery, the ENT unit of Teaching Hospital Anuradhapura is noteworthy for operating the country's only state-of-the-art comprehensive balanced laboratory and successfully conducting the neonatal hearing screening program. I am also happy that I could contribute to establish the cochlear implantation program here in Anuradhapura. Moreover, your hospital is now considered as a major postgraduate training center, training large number of medical postgraduates in many fields. These important and progressive developments should best be accompanied by several other programs and collective activities to achieve the best possible outcome in healthcare and in medical education. One such activity is to arrange continuous professional development programs, CPD programs, for all sorts of health professionals. This will ensure that the medical care provided will be of high standard, cost effective, And I think the Anuradhapura Medical Association has very well realized the importance of such CPD activities and now has come forward with a vibrant academic program arranged throughout the year. I understand that you conducted many joint academic sessions with specialist academic associations, and also you had conducted some sessions with general public, which is very highly desirable. In spite of being a newly established medical association, your association has managed to come out with an excellent annual academic sessions with a comprehensive and very relevant academic program. This certainly is commendable, and I must thank the organizers profusely for their dedication, commitment, and hard work, as I know personally how difficult to organize medical conferences of this caliber, especially away from the capital. The other important activity that your association should promote is medical research, and especially clinical research. I myself is not a keen researcher, but I realize that the research and audit, although may not be groundbreaking, should be supported and promoted at every level to make the healthcare more effective, meaningful and cost-effective, especially in a limited resource setting. As busy clinicians, there is very little time available to us to get engaged in extensive research. On the other hand, these busy clinical settings provide ample and best opportunities to do clinical research, as there is good case load and a good case mix. I am sure that your association will promote and support local research, and annual academic session certainly will provide the necessary forum to present these research findings to the wider audience. Another important area your association need to pay attention is to ensure and encourage the best ethical behavior of medical professionals. Time to time we see in media, especially in the social media, bringing out so-called not so ethical or unethical behavior of health profession in all sectors. It ranges from issues in providing proper and inadequate medical treatment, maintaining privacy and confidentiality, rashness amount to negligence, charging so-called exorbitant professional fees, inappropriate behavior with patients and trainees, and many more things. And I agree that sometimes these claims are not justified and may have arisen out of poor communication. Some even argue that there is an organized attempt by the people with vested interests to discredit and tarnish the image of medical doctors. Even if this is true, it is best to encourage and ensure the proper ethical behavior in all occasions. Nowadays, medical ethics and communication skills are taught both in undergraduate and postgraduate medical programs, and many guidelines were issued both from the Sri Lanka Medical Council and from many medical associations or academic bodies. All these are important, but finally, what matters is to adhere and to practice these principles in everyday practice. Here, the presence of role models is of much importance, as it is well known that juniors follow what seniors do, and this is especially true in medical profession. Hence, it is imperative to always be good role models and display adherence to the ethical principles with touch of common sense during the clinical practice and training. As I now retired from state health sector in last month, many ask me how I value, evaluate, and recognize the services and roles played by medical specialists working in the state health sector. When I look back into my career, I realized that how much a medical specialist working in a state hospital can do to improve the health and related fields of our country. Most of you are working here in Anuradhapura are the best example to prove this point. As a government medical specialist, you can provide the best care to your patients who may not come from a fluent part of the society. You can provide your expert advice where it is needed and provide advocacy both at local and at national level. You can teach medical students and train postgraduates and even get involved in the activities of the PGIM. You can also get engaged in academic activities through your academic colleges and associations. You can make an attempt to promote best working conditions and proper recognition of your services to a collective action of a trade union. Although I will not promote any particular trade union at the moment, it is vital that the medical professionals realize the value and the power of the collective action, especially during the time of changing landscape of the medical workforce. More and more women are joining the medical workforce now, and this needs adequate representation and involvement of women doctors in decision making in both medical associations, academic institutions, and in trade unions. I can assure that all the above mentioned activities will reward you with a different level of satisfaction and contentment, much different to and arguably better than most of the monetary gains you can think of. My own philosophy applicable to working in the state sector revolves on two principles. First, you must do best though you may not become the best. But secondly, stick to the motto that the world may not be fair at times, but we have to be fair always. With that note, I sincerely hope that your association, though very young, will continue to conduct good continuous professional development programs, promote and support clinical research, always encourage the best ethical behavior, and your members will always demonstrate public spiritedness through enthusiastic collective action. Let me thank you again for inviting me and organizing the remarkable conference. I wish your conference and your association all the best. Thank you very much for patiently listening.
Thank you very much, sir. We extend our deepest appreciation for your profoundly meaningful and most engaging address. May I kindly request you to come back onto the stage to receive the token of appreciation. We now also invite President Dr. Priyankika Gamage to present the token of appreciation to the guest of honor. Thank you, sir and madam.
May I now respectfully invite our President, Dr. Priyankika Gamage, back to the podium to introduce our chief guest and deliver the citation.
It is my distinct honor to introduce our distinguished chief guest for this inauguration, Vidya Jyoti Professor Prasad Katlanda. Professor Katlanda currently serves as the president of the Ceylon College of Physicians for the year 2025. Academically, he is the professor and head of the Department of Clinical Medicine at the Faculty of Medicine, University of Colombo, and an honorary consultant endocrinologist at the National Hospital of Sri Lanka. A distinguished alumnus of the University of Colombo, Professor Katlanda graduated with the first class honors and was named Student of the Year. He later obtained his degree of philosophy from the University of Oxford at the prestigious Oxford Centre for Diabetes, Endocrinology and Metabolism. Professor Katlanda is one of Sri Lanka's most preeminent researchers. He was the principal investigator of the Sri Lanka Diabetes and Cardiovascular Study, the first ever nationally representative study to define the prevalence of diabetes and non-communicable diseases in the country. His seminal contributions to research in diabetes, obesity, and metabolic syndrome are internationally recognized, with over 170 publications and more than 12,000 citations. For his outstanding contribution to scientific research, he has been honored with multiple presidential awards for scientific publications and the esteemed National Titular Award of Vidya Jyoti. He has also provided immense national leadership, serving as a presidential advisor on health and on numerous national steering committees. As president of the Ceylon College of Physicians, he champions the visionary theme, Physician for the Future, empowering physicians to meet emerging global challenges. Ladies and gentlemen, please join me in offering a very warm welcome to our esteemed chief guest, Vidya Jyoti Professor Prasad Katlanda.
Thank you, Madam President, for those very generous words of introduction. Everyone, good evening. The guest of honor, Dr. Saman Yasawardana, the President of the Anuradhapura Medical Association, Dr. Priyankika Gamage, the orator tonight, Professor Sisira Siribadana, the Joint Secretaries and the members of the Council of the Anuradhapura Medical Association, distinguished invitees, ladies and gentlemen. I consider it a great honor to be invited as the chief guest at the inauguration ceremony of the inaugural academic sessions of the Anuradhapura Medical Association. I would like to thank the President and the Council for this singular honor of inviting me as a chief guest and the honor bestowed upon me by your invitation. I'm bringing in greetings from the Ceylon College of Physicians and all the good wishers, and also from the Faculty of Medicine, University of Colombo, to the Anuradhapura Medical Association. And I would like to also congratulate the Anuradhapura Medical Association for establishing such a high caliber academic professional association in Rajarata to steer the dissemination of knowledge and improve professionalism among the doctors in this region. I'm also particularly proud that I'm standing here because it's the Ceylon College of Physicians which had the first academic activity of your association when we conducted the regional meeting of the Ceylon College of Physicians at Anuradhapura early this year. And all of us are aware that Anuradhapura is our first capital, which symbolizes our distinguished past heritage, a city that flourished with advanced irrigation, architecture, the agriculture, and also the medical practices many thousands of years ago. The spirit of innovation, resilience, and dedication that built this great civilization continues to resonate today by the work of all of you. Particularly the teaching hospital of Anuradhapura, now coupled with the Rajarata Medical Faculty, is doing a yeoman service and also had been doing a yeoman service, particularly from the times of great malaria pandemics and dealing with multiple issues like snake bites related to tropical medicine and also the issues related to our agricultural farming communities. And also lately, for several decades, handling hundreds or thousands of war casualties during the war, and now transforming along with these traditional burdens, tackling the problems of modern day, the ill effects of the modern civilization, like the NCD pandemic, diabetes, hypertension, obesity, and all the ill effects of the modern lifestyles. I have made long-term friends in Anuradhapura and have taken time whenever possible to come here as an examiner as well as in various regional meetings in Anuradhapura. We are in an era where there is rapid evolving of the medical profession. In this era, it is very vital that we blend our deep local experience with global innovations and advances in science, technology, and particularly in areas like artificial intelligence as well as ethics. As medical professionals, we must remain lifelong learners, and I am particularly impressed with your theme, rooted in heritage, advancing through science, and the deliberations that you are going to make during the next couple of days, where there is a lot of exchanges in your experience and also addition of new knowledge to the medical professionals here. I would like to have a theme for my talk, the medical professional for the future, the compassion, competence, and innovation. The medical professional for the future should be a compassionate person. And we know that the compassion is what distinguishes doctors from other lay people. And particularly, these three pillars, the compassion, competence, and innovation, forms the foundation of the future medical professional. And compassion is not merely sympathy, it is empathic action and the ability to listen, connect, and to treat each patient as a person, similar to one of your parents, your siblings, your relatives, or your friend, not just as a case, a diagnosis, or a number. Let us recall the words of Sir William Osler, who said, I quote, "The good physician treats the disease, and the great physician treats the patient who has the disease." I unquote. So, even though we would introduce new technologies from things like continuous glucose monitoring, AI-assisted diagnostic tools, AI-assisted robotics, we need to remember that patients do not come to us to follow algorithms. They come to us to have reassurance, comfort, understanding, and because of the trust that they have on us. Compassion also extends to our colleagues and trainees. And as leaders and mentors, we must cultivate the culture of kindness and respect, especially for our young colleagues as well as trainees. And in times of great hardships and chaos, we experience, particularly during the pandemic and also economic crisis, and particularly I think you all would have experienced this during the war, the compassion became not just a virtue, but a lifeline that bounded our profession with the community. The next pillar is competence. This is the second essential quality of all the medical professionals. This is the mastery of knowledge, skills, and judgment. And in an era where the medical knowledge is expanding very rapidly than ever before, the theories that we thought and considered as gospel truth is fast changing. For instance, if we treated a patient with heart failure about 20 years ago with beta blockers, we might even have to end up in jail or being sued for that. But now, the beta blockers is one of the cornerstones in the management of heart failure, and if we don't do that in a particularly recommended patient, we can be also in trouble. So you can see the medical knowledge is changing very rapidly. Therefore, it is very important that all of us considers continuous professional development not as an option, but an essential component of all our lives and careers, and as a mandatory requirement. At Ceylon College of Physicians, we have taken a lot of efforts this year to take forward our CPD initiatives. Particularly, we have established a portal for physicians, which we might in future open up for other specialties and other colleagues. And I would like to invite all of you to make use of the portal once it is fully operational. In addition, the competence is also the humility, the readiness to learn from others, to adapt, to change, and to recognize our limits. A doctor for future is one who never stops learning. The third important pillar is innovation. Innovation defines our profession's evolution to the next century. And in Sri Lanka, innovation in medicine is not just about high technology or introduction of artificial intelligence or robotics in surgery. We need to be creative to find solutions to our indigenous problems. In that way, I would like to also appreciate the efforts taken by our colleagues in Anuradhapura, particularly in finding solutions to problems like CKDU, snake bite, and poisoning. Innovation also must address real changes. Particularly, we know that about the gravity of the NCD pandemic, so we should all try to find solutions, homegrown solutions to these new challenges. Innovation also includes how we teach. We need to change the way we teach our next generation. Also incorporate new technologies, new methods as they emerge. In addition to these three pillars, we have a big social role. The future doctor must not confine ourselves to hospitals. We are healers, we are educators, we are advocates, as well as we are leaders within the community. So unless we fulfill all these duties, we will not be fully accomplished health professionals. The other important thing is the patriotism and the eager to serve the nation. I would like to thank particularly all of you who have stayed back in this country, as well as who are serving the people with less resources compared to people in Colombo, and also amidst multiple challenges. Some people might think that we have got the ladder, the education ladder, to transform ourselves from one class to the other, and also use that as a passport to go and work and serve a first-class country. But I think we should mold our new generation and also appreciate what the society have done to us. We have all here because it may be the poor farmers who have paid indirect taxes, or the richest of the rich who have paid their taxes to educate ourselves. And so we have a duty to serve our people, and also whether it is in London or whether it is in Melbourne, I think the Sri Lankan doctors and the medical professionals, if you are keen to work hard, you are happy to make challenges into opportunities, I think all of us can work much better than anywhere in the world and have a career fulfillment, as well as serve our motherland as well as the humanity. So, ladies and gentlemen, in the closing, the compassion, we have the three pillars: the compassion, which humanizes our care, and the competence, which guarantees the safety and excellence, and the innovation, which ensures progress. If we lose compassion, we lose our human touch. If we lose competence, we lose the credibility. And if we lose innovation, particularly in this rapid transformation era, we will lose the relevance and we would be obsolete as a profession or even as individuals. So we need to all strive forward with these sort of activities by updating ourselves to these challenges. And I would like to again thank the President and the Council of the Anuradhapura Medical Association for inviting me, and congratulate all of you for establishing this new association and on the first academic sessions. And I wish that this will be a great success, and also I wish success for the Anuradhapura Medical Association in all your future endeavors. Thank you very much.
Thank you very much, sir, for that thought-provoking and insightful speech. To award him the token of appreciation, I would like to invite the President of Anuradhapura Medical Association, Dr. Priyangika Gamage. Thank you, sir and madam.
Ladies and gentlemen, we are about to begin the most anticipated segment of today's evening's inauguration, a talk that brings science, experience, and clinical insight together in a unique and thought-provoking way. Medicine advances not only through technology or laboratory innovation, but also through how we understand what happens in our day-to-day clinical encounters. Every specialty contributes to that understanding in its own meaningful way.
Some discoveries come from large trials and advanced investigations, and some start quietly from a single patient, a single clue, a single observation that invites deeper thinking. Tonight, we focus on how such observations can grow into knowledge that benefits all disciplines, from laboratory sciences to clinical practice, from research to real-world healthcare. It is now my privilege to invite the President of Anuradhapura Medical Association, Dr. Priyangika Gamage, to introduce the orator, read the citation, and to present the memento and felicitation to the orator.
Ladies and gentlemen, it is my great pleasure to introduce our orator of the first Oration. We have received several applications for this oration, and the orator was selected through a rigorous peer-review process, looking at multiple dimensions, including the scientific rigor of the oration, quality of the scientific publications, and the applicant's role in the publications included in the oration, and also the relevance. Accordingly, the selection panel unanimously decided to award the inaugural Anuradhapura Medical Association oration to Senior Professor Sisira Siribaddana. Senior Professor Sisira Siribaddana is the founder chair Professor of Medicine in Rajaratna University of Sri Lanka. He obtained MBBS in 1986 and MD in Medicine in 1995 from the University of Colombo, Sri Lanka. He is a Fellow of Royal College of Physicians of London and Edinburgh. He is a Fellow of the Ceylon College of Physicians. Professor Siribaddana has been teaching clinical medicine since the first batch of medical students of the Rajaratna Medical Faculty, producing more than 2,500 doctors. He has trained more than 50 physicians and has supervised more than 20 PG trainees. He was the first permanent dean of the medical faculty in Rajaratna University of Sri Lanka and served 2 full terms in the post. He has been serving as a member of the Board of Management of PGIM Colombo since 2014 and as a council member of the SLMC for 6 years. Professor Siribaddana is an eminent scholar. He has published extensively with more than 220 publications indexed international journals. He has an H-index of 46 with over 4,700 citations, spanning topics such as diabetes, mental health, tropical diseases, disasters, migration, bioethics, snake bites, and chronic kidney disease. His work has appeared in leading journals including The Lancet, BMJ, PLOS Medicine, and the British Journal of Psychiatry. He is an editorial board member of the prestigious journals PLOS 1, Ceylon Medical Journal, and Indian Journal of Medical Ethics. He has authored several books and national clinical guidelines, and served in academic and bioethics leadership roles. Professor Siribathana was instrumental in establishing the Ethics Review Committee and postgraduate degrees based on peer-reviewed publications in the Rajarata Medical Faculty. He has delivered several prestigious orations. He was a member of the Center of National Operations for Post-Tsunami Rehabilitation at the Presidential Secretariat and a clinician in charge of Medsiri Sevana, the COVID-19 treatment center in Anuradhapura. Professor Siribathana's early clinical and research training included work in endocrinology at the Princess Alexandra Hospital in Brisbane and a tutor at the University of Queensland. He co-founded the Sri Lankan Twin Registry, supported by the Wellcome Trust, pioneering twin research in South Asia. Professor Siribathana's career reflects an enduring commitment to advancing medical science, ethical research, and equitable healthcare, bridging global collaboration with pragmatic public health practice in Sri Lanka. Over to you, sir.
Madam, to present the felicitation, I would like to invite you back to the stage.
Thank you for the kind introduction. President of the Anuradhapura Medical Association, Dr. Priyangika Gamage, Chief Guest, Professor Prasad Katulanda, Guest of Honor, Dr. Samanya Asawardhana, Vice Chancellor, Dr. Janaka Pushpakumara, Director, Cheating Hospital, Anuradhapura, Dr. Nalin Aryaratna, Provincial Director of Health Services, Dr. Champa Alutvira, Council members, distinguished guests and friends. Case reports and series play a foundational role in clinical medicine. They serve as early signals for new diseases such as AIDS, unique presentation of known conditions such as myocardial infarction presenting as ear pain, rare adverse drug reactions such as thalidomide embryopathy, or unforeseen complications such as vaccine-induced thrombotic thrombocytopenia. Case reports contribute to hypothesis generation, alert clinicians to emerging trends, and can rapidly disseminate crucial bedside observations, especially in resource-limited or rapidly evolving clinical settings. By revisiting case reports and series, these short stories illustrate how observation becomes evidence, fueling discovery, deepening understanding, and refining the practice of medicine. The first story is about tuberculosis. The 37-year-old man presented with central chest pain, shortness of breath, anemia, and icterus in 1991. An initial diagnosis of autoimmune hemolytic anemia was made based on blood investigation, but the patient requested discharge. 1 month later, he was admitted with high intermittent fever and palpable tender submental lymph node. Whole agglutinin titers were high. The biopsy of the submental lymph node was compatible with the diagnosis of TB lymphadenitis. Fever subsided within 4 days of starting anti-TB treatment. We conducted a systematic review to contextualize frequency, clinical spectrum, and treatment outcomes
of autoimmune hemolytic anemia. TB-induced autoimmune hemolytic anemia is a rare complication. It's very rare, with all reported cases showing a positive direct Coombs test. The exact mechanism is unclear, but is likely to involve an altered immune response triggering IgG and IgM antibodies, leading to warm or cold or mixed type autoimmune hemolytic anemia. Although AIHA or autoimmune hemolytic anemia itself is uncommon, TB-induced autoimmune hemolytic anemia is even rarer, mainly reported from India and Southeast Asia, reflecting the high TB burden on TB-induced autoimmune hemolytic anemia. The diagnosis of TB pericarditis can be challenging, as pericardial aspirates for acid-fast bacilli and MAN to yield negative results. In such cases, anti-TB drugs can serve as a diagnostic aid. Steroids are vital adjuvant therapy, typically initiated after the fever has responded to anti-TB drugs. Clinical trials have shown that adding steroids significantly increases recovery rate, reduces the risk of death, and decreases the need for pericardiotomy. Taken together, these observations underscore two distinct but clinically meaningful immune pathways in TB: antibody-mediated cytotoxicity in autoimmune hemolytic anemia, and the T-cell-mediated delayed hypersensitivity driving pericarditis. These antibody-mediated mechanisms contrast sharply with the other significant immune-mediated complications of TB, namely tuberculous pericarditis, where tissue damage arises predominantly through a delayed type hypersensitivity reaction rather than direct autoantibody production. A pericardial fluid in tuberculous pericarditis is typically blood-stained and non-clotting due to fibrinotic activity and immune-mediated mechanisms. The next story is about an environmental disaster. In early 1994, a surgical glove manufacturing plant in Homagama became a scene of an unexpected health crisis. 40 employees were rushed to Sri Javadapura General Hospital, where I was working as a registrar, presenting with headache, burning sensation in their eyes, and muscle pain. Over the next few days, 8 more workers were admitted, raising concerns about an occupational cause for their sudden illness. Interestingly, 11 employees from the accounts department and 2 workers on leave remained unaffected, pointing strongly to an issue on the factory floor. Inspection of the factory revealed barrels used to transport latex from the estate has been recently changed. These barrels had previously contained toluene diisocyanate. Despite clear warning labels advising against reuse, these barrels had been washed and repurposed for transporting latex. The workers had even noticed a change in the latex itself, a different smell, color, and delayed drying, though they couldn't identify the reason. The affected workers exhibited mucosal irritation of the gastrointestinal and respiratory tracts, skin inflammation, and conjunctival irritation. Some even experienced neurological symptoms such as euphoria, ataxia, and memory loss. A notable finding was that 32 of the 40 patients experienced muscle pain and even showed elevated creatinine phosphokinase, indicating striated muscle involvement. Muscle involvement has not been previously reported in toluene diisocyanate toxicity. Chemical analysis of the latex was performed at the Ceylon Institute of Scientific and Industrial Research using infrared spectroscopy. Production at the glove plant resumed with fresh latex transported in new barrels. No workers subsequently fell ill. The highly reactive nature of isocyanates, due to their NCO group, is responsible for their intense irritative action rather than the hydrogen cyanide, which is different. In a chilling parallel, methyl diphenyl diisocyanate gas, another isocyanate, accidentally escaped from a storage in Bhopal pesticide manufacturing plant, causing around 8,000 deaths. This highlights the importance of preventing the reuse of containers that have previously held toxic substances. In the late 1970s, a series of patients in Sri Lanka's central province developed toxic polyneuropathy after consuming sesame seed oil that has been stored in containers contaminated with triglyceride phosphate. Actually, this is not a short story, but a long novel with several sequels. Several chapters in the prologue guide us to find the real culprit in the chronic kidney disease of unknown origin. We are proud to say the epidemic of chronic interstitial nephritis among agricultural communities, or CINAC, has been successfully controlled now. A 23-year-old military trainee who developed early renal failure, liver failure and rhabdomyolysis after participating in a 9-mile truck march in hot, humid conditions, 37 centigrade, 76 humidity. Despite adhering to preventive measures, he collapsed near the finish line with convulsions, delirium, loss of consciousness and reduced sweating. The case highlights the heat stroke and acute kidney injury can occur even in young, otherwise healthy individuals despite preventive strategies. This case prompted us to consider whether repeated subclinical heat stress and dehydration could similarly explain chronic interstitial nephritis among agricultural communities, or CINAC, seen in Sri Lanka and elsewhere, especially in Mesoamerican or Latin American countries. However, two of our papers cast significant doubt on the heat stress hypothesis. The first is a review that critically examines the evidence and finds little support for the idea that recurrent mild AKI from occupational heat exposure drives chronic interstitial nephritis among agricultural communities. We noted that global warming has not caused comparable epidemics of kidney disease in other hot climates, that AKI among manual workers is rarely severe enough to progress to chronic kidney disease, and that alternative etiologies such as agrochemicals, heavy metals, and fluoride warrant greater scrutiny. Further undermining the heat stress theory, we studied school children in Sri Lanka's dry zone and compared those with high versus low outdoor heat exposure. They found no significant differences in urinary markers of kidney injury, like kidney injury molecule 1, KIM1, albumin creatinine ratio. However, neutrophil gelatinase associated lipocalin, NGAL levels varied, possibly due to exercise-induced muscle stress. Importantly, urinary KIM1 was constantly higher in children from CINAC endemic areas, regardless of heat exposure, suggesting environmental or geographic factors unrelated to heat stress. Recent methodological sound meta-analysis come to the following conclusions. There was no consistent evidence from our systemic review to support the association between chronic kidney disease and heat stress dehydration. Although heat stress and dehydration as a cause of chronic kidney disease have some biological plausibility, to the best of our knowledge, there are no studies that indisputably show that they are the single or preponderant cause of the onset of the so-called chronic kidney disease of the non-traditional etiology. Taken together, our case report demonstrates how acute heat stress can clearly damage the kidneys in susceptible settings. However, the epidemiological and biomarker evidence from Sri Lanka argues that heat exposure as the central driver of CINAC. Instead, heat may act as a secondary aggravating factor, with environmental nephrotoxins more likely playing a primary causal role. The linkage from an individual case of exertional heat stroke to population-level investigations illustrate how bedside observation can stimulate broader inquiry and how careful research can help exclude an initially plausible but ultimately insufficient hypothesis. Russell's viper and Merriam's hump-nosed pit viper are known to cause AKI. 4 patients presented to teaching hospital Anuradhapura with renal manifestations following snake envenomation. Patient 1 with immediate and prolonged anuria, patient 2 with delayed anuria, both requiring dialysis with one leading to fatality. Patient 3 and 4 with clear signs of CKD maintained normal urine output without progressing to AKI, despite elevated creatinine and other complications. All 4 had previously documented high creatinine or contracted kidneys in ultrasound. While previous reports by Vijay Vikrama and Herath suggested that AKI from snake envenoming could progress to CKD, be investigated this further. Rajarata has high incidence of both snake bites and CNAC. As there were no cohort studies, we investigated the long-term kidney effects of snake envenoming to explore the possibility of developing CKD. We prospectively followed 2 groups of confirmed snake bite patients from the Anuradhapura snake bite cohort. 199 patients in group 1 reviewed after 4 years and 168 patients in group 2 reviewed after 1 year. The study found no significant association between snake bite associated AKI and the development of CKD. Among the patients who experienced AKI after snake bite, 12 in group 1 and 9 in group 2 all had normal estimated glomerular filtration rate at their 1 and 4 year follow-ups. Importantly, all 9 patients across both groups who did have a low estimated glomerular filtration rate consistent with CKD stages 3 to 5 at the time of review were found to have been diagnosed with CKD before the snake bite or were receiving treatment for comorbidities like hypertension or diabetes. Although microalbuminuria was common, affecting 25% of group 1 and 26% of the group 2 patients, it was strongly associated with known comorbidities for CKD rather than snake envenoming or snake bite associated AKI. The observed renal abnormalities, including microalbuminuria, were more likely attributed to background conditions like hypertension, diabetes, and endemic CNAC or chronic interstitial nephritis among agricultural communities. In this rural farming population, rather than being direct consequences of snake bite or snake bite associated acute kidney injury, the study found no evidence supporting an association between snake bite induced AKI and chronic interstitial nephritis among agricultural communities. Following the emergence of chronic interstitial nephritis among agricultural communities, the WHO recommended regulating herbal medicines that contain aristocolic acid, an established nephrotoxin, as a control measure. This recommendation is based on speculation, as the available information is inadequate to justify restricting the use of Ayurvedic medicine, which has existed in Sri Lanka for over 2,500 years. The use of native species, Aristocolia indica or sapsanda, is sparse in Ayurveda, often appearing as a minor ingredient in polyherbal compounds, many of which are used externally. Crucially, the cumulative doses and duration of use in Ayurveda are much lower than the intake levels known to be associated with aristocolic acid nephropathy. A cumulative oral intake of 150 grams or more is necessary to cause aristocolic acid nephropathy. Furthermore, no clinical report exists in Sri Lanka linking CKD to the consumption of aristocolia as part of Ayurvedic treatment. Hence, regulating such medicines without proper data risks undermining traditional medical practices and requires rigorous research before making policy decisions. A case series of several case reports of distal renal tubular acidosis coexisting with Southeast Asian ovalocytosis have been reported, all from Rajarata. These patients present with severe hypokalemia and paralysis, with distal renal tubular acidosis confirmed by normal anion gap, hypochloremia, high urine pH, and positive urine anion gap. The presence of stomatocytes and abundant ovalocytes identified Southeast Asian ovalocytosis, a condition more commonly described in Southeast Asian countries but rarely outside Rajarata in Sri Lanka. All the reported cases are from Rajarata. Complications observed included CKD, medullary nephrocalcinosis, and metabolic bone disease. Familial renal tubular acidosis and Southeast Asian ovalocytosis can be co-inherited through mutation in the SLC4A1 gene, while the characteristic erythrocyte rigidity in South Asian ovalocytosis is believed to confer protection against malaria. Clinically, recurrent or chronic hypokalemia should prompt investigation for distal renal tubular acidosis as early diagnosis and correction of acidosis to prevent CKD progression. Interestingly, patients with chronic interstitial nephritis among agricultural communities in Sri Lanka and Mesoamerica also display hypokalemia and electrolyte disturbances, raising questions about overlapping mechanisms. However, unlike inherited renal tubular disorders, the etiology of chronic interstitial nephritis among agricultural communities is considered multifactorial. Substantial evidence implicates occupational and environmental exposures, particularly agrochemicals and heavy metals, as primary triggers, with heat stress and recurrent dehydration acting as contributory but insufficient factors. A new perspective emerged from renal histopathology, revealing enlarged dysmorphic lysosomes with granular content in proximal tubular cells, a lesion highly characteristic of toxic-induced nephropathies. Strikingly, these findings resemble those observed in nephrotoxicity associated with calcineurin inhibitors, suggesting that pesticides that interfere with calcineurin pathway may cause chronic interstitial nephritis among agricultural communities. This positions SINAC as a toxin-induced proximal tubular nephropathy, distinct from genetically determined tubular disorders, yet sharing common clinical thread of tubular dysfunction and electrolyte imbalance. Implementation of reverse osmosis water purification as public health intervention resulted in a marked reduction in chronic kidney disease incidence, suggesting a primary role for waterborne nephrotoxins in disease etiology. The last story is about deadly bug, a methicillin-resistant Staphylococcus aureus. In 2013, 4 young immunocompromised males presented with pneumonia. Thank you. Thank you very much. In 2013, 4 young immunocompetent males presented with pneumonia to Teaching Hospital Anuradhapura. These patients developed severe respiratory distress, which rapidly progressed to necrotizing pneumonia, requiring assisted ventilation. Key clinical features included preceding flu-like illness, acute respiratory distress, and complications such as pleural effusion, pneumothorax, cavitation, and pneumatocele. Positive blood cultures confirmed the diagnosis of MRSA. Aggressive therapy with combination of antibiotics such as vancomycin, clindamycin, and especially linezolid proved very effective. All 4 discharged. We speculated that pentan-valentine leukocidin toxin secreting MRSA was the cause of this severe necrotizing pneumonia. Excuse me. We performed genomic analysis of MRSA isolates from Sri Lanka, collected from Teaching Hospital Anuradhapura in 2014. This study aimed to characterize the presence of MEC-A and MEC-C genes and pentan-valentine leukocidin associated genes using staphylococcal protein A typing or SPA typing and whole genome sequencing or WGS. All 94 MRSA isolates harbored MEC-A, MECA, while most isolates, about 77%, were associated with skin and soft tissue infections. 23 caused invasive infections. Crucially, 66% of the isolates were pentan-valentine leukocidin positive, and the vast majority of these, 90%, belong to the dominant clonal complex or CC5 lineage, specifically PVL positive sequence type 5 MRSA4C. This prevalent lineage was found in both community-acquired and hospital-acquired infections, highlighting the increasingly blurred distinction between these settings. Whole genome sequencing analysis further demonstrated that representative pentan-valentine leukocidin positive sequence type 5 MRSA4C isolates from Sri Lanka, England and Australia formed a single phylogenetic clade suggesting wide geographical circulation of this clone. The genomic study explains the severe clinical cases of necrotizing pneumonia due to community-acquired, highly virulent Phantom-Valentine leukocidin positive sequence type 5 MRSA4C lineage in Sri Lanka. Therefore, the second study provides the molecular evidence of the clinical threat posed by the community-acquired MRSA in Sri Lanka, demonstrating the widespread presence of highly pathogenic clone responsible for the severe outcomes observed in the first study. And now this is termed as Sri Lankan clone. The third paper is the most detailed analysis that we did in 2021. It provides genomic and epidemiological analysis of Staphylococcus aureus, investigating its circulation between community and healthcare settings. This prospective longitudinal cohort study was conducted at Teaching Hospital Anuradhapura in 2021. A total of 153 participants, including Staphylococcus aureus positive index patients and their household contacts, were recruited for the study. The study found a baseline Staphylococcus aureus colonization prevalence of 12% among healthy household contacts, with 30% of these isolates being MRSA. Whole genome sequencing of 88 isolates revealed 3 predominant multilocus sequence types, all of which were identified in both community and healthcare environments. Notably, sequence type 5 isolates exhibited a more virulent phenotype, with 100 being Phantom-Valentine leukocidin and MEK positive and typically harboring staphylococcal cassette chromosome MEK4C. Interestingly, the study did not detect household transmission of the index patient's infecting strain, suggesting that household decolonization strategies may be less effective in this setting than in others. The studies provides further evidence for the persistent presence of highly virulent Phantom-Valentine leukocidin positive sequence type 5 MRSA4C lineage in Sri Lanka, which we identified as a dominant clone in 2014 isolates, linking it to both community and hospital onset infections and to its widespread geographical circulation. Therefore, the genomic and epidemiological data provide a contemporary molecular basis for the aggressive Staphylococcus aureus infections observed clinically, highlighting that Phantom-Valentine leukocidin positive sequence type 5 strains, which are considered highly virulent, remain a concern in the public health landscape. Conclusion. These examples collectively demonstrate that attentive clinical observation, coupled with systematic follow-up and modern investigative tools, transforms anecdote into evidence. Case reports not only alert us to new diseases and hazards, but also refine understanding, prevent misattribution, and guide public health and therapeutic strategies. The enduring value of case reports lies in their ability to bridge bedside observation with scientific discovery, ensuring that what begins as a single patient story can evolve into evidence-shaping medical practice, research priorities, and health policy. The acknowledgements are deeply personal. Samavati Jayasinghe, to the world, you are a pioneer who helped shape the Sri Lankan police force. To us, you are simply Amma. For 28 years, we watched you fight a fierce battle against breast cancer with courage. You were my safe harbor and your listening ear with gift that made me feel heard, valued, and loved. I carry your strength with me every day. Kirtinanda Siribaddana died just after receiving a first gift from his politically exiled, argumentative son. He taught himself English in night school, and even now, I find his command of it puts my own to shame. Manel, Mahika, and Nipuna. Manel, for 40 years you have been my unwaveringly strength and deepest source of grace. and everything I have achieved is no small part because of her quiet courage and steadfast belief on me, even in my failures. Mahika and Nipuna has grown and as capable adults. Your love continue to enrich me. Professor Devaka Fernando, visionary clinician and educator, is a guardian angel of me and my family. Thank you, Devaka. The two PhD students among many. Channa, who is not among us today, is in Australia, actually in Czechoslovakia, Bratislava, and Anjana, who is here with me. I don't have words to talk about them. I learned from them more than they learned from us, I think. And the department staff who helped me throughout my journey, Prasanna, Chamara, Hemal, and the two young guys, Lanka and Pilina. The past staff, Professor Dahanayaka, Professor Pilipitia, Nuan, Ruanti Bandara, and Oration Lokunarangoda. And the non-academic staff, Mr. Sugadadasa, Shanika, Mr. Senaratna, and Mr. Pushpalal, who have helped me throughout my stay in Rajarata. And my senior registrars, Anuranga, Vasanta, Ranabahu, Lalite Attanayaka, Karu Prasanna. I may have missed some, Bhatia, Sujiva, Janaka Ambagammana, Isru Ahesh, some of them are here, Namal Herat, Manod Disanayaka, who is in Australia, Pasan, Inu, and Darsha Kumaravadu, who is going to stay with us probably. And my teachers and my mentors and friends and colleagues, Dr. Anura Vijayasundara and Dr. Chula Herat, who was my boss in when I was doing registrar. Late Dr. Nalin Rodriguez, who recruited me to Sri Jayawardenepura Hospital after my political exile. Dr. H.H.R. Samarasinghe, Professor Iswi Sharif, Professor Sarat Lekamvasam, Professor Malini Udupil, and Professor Sarat Edesinghe, who helped me here. Late Dr. Milo Ganesharatnam, who was my intern boss, and Dr. Ira Senanayaka. Professor Mangala Chaturadi Silva, Professor Sulo in Runa, who we did a lot of collaborative works, and Dr. Sarat Gunatilaka from California, sir. And my foreign collaborators, Professor Jeff Fiswister, Dr. Thomas Locke, and Dr. Tom Darton, Professor Dushanti Silva, all from MRSA group in Sheffield, people who have stayed with me in difficult times in late 80s, Sudat, Atula, Nihal, and Vasanta. My students, PhD students mainly, Dr. Samira Gunasekara, Dr. Devani Ranavira, MD student, Professor Tilini Agampodi, Dr. Mudita Ratnayaka, Dr. Roshan Lienegi, Dr. Suja Mohammed, Dr. Subodha Vaidanta, late Dr. Bimba Gonapinuala, Mr. Prabhat Pallevatta, who is in USA, Mr. Umesh Chaturanga, and Supun Vedasinghe. People who have helped me during my Rajarata journey, Kosala, Nuan, both are here, Sampath, Javira, Professor Sunetta Gampodi, who is not with us today, Professor Ratish Devarajan, Professor Janit Varanasekara, Mr. Ranga Edirisinghe, who is not here, Dr. Subhashini Senadira, Dr. Shobha Gunatilaka, Mr. Lalit Kumarasinghe, Sepa and Osman Karasinghe, who is in Singapore with illness, Sister Udayangani and Vatsala and nursing staff in Ward 61 and 62, Mr. Chalaka Kumarasinghe and lab staff, all my colleagues in teaching hospital, Anuradhapura, all the other colleagues and other healthcare workers in teaching hospital, Anuradhapura. Thank you very much.
Thank you, sir, for your inspiring oration. You have beautifully highlighted that while technology and research propel medicine forward, it is our day-to-day clinical experience and unique contribution of every specialty that deepen our understanding and guide our progress.
Ladies and gentlemen, we now arrive at another truly special moment, a moment that represents growth, achievement, and the pursuit of excellence. This is a moment that not only celebrates our accomplishments, but also sets the stage for new opportunities, innovations, and contributions to our field.
It is now my honor to invite The President of Anuradhapura Medical Association, Dr. Priyangika Gamage, Chief Guest, Vidya Jyoti, Senior Professor Prasad Katulanda, Chief Editors of Journal of Tropical Health, Professor Anjana Silva and Professor Kosala Veerakorn, to formally launch the third issue of the first volume of Journal of Tropical Health.
Ladies and gentlemen, what you have just seen marks a milestone in our academic journey. Now, I would like to invite the dignitaries to formally launch the third issue of the first volume of Journal of Tropical Health.
We extend our heartfelt thanks to our President, the Chief Guest, and the Chief Editors of the journal for formally inaugurating this milestone. With the launch of the Journal of Tropical Health, a new platform for innovation, research, and knowledge in tropical medicine is now open to the world. I encourage each and every one of you to explore, contribute, and witness how this initiative will shape the future of medicine.
Ladies and gentlemen, we now come to another important and much anticipated moment of this evening, the recognition of outstanding talent and achievement through our annual awards. These awards celebrate dedication, excellence, and commitment in the medical field, and it is our privilege to honor those who have distinguished themselves over the past year.
We begin with the recognition of outstanding talent through our annual Anuradhapura Medical Association academic scholarships. These scholarships are awarded exclusively to medical officers and postgraduate trainees who have demonstrated exceptional dedication, academic excellence, and promise in advancing medical knowledge and practice. This year, we are delighted to award Anuradhapura Medical Association Travel Scholarship, a grant designed to support participation in credible academic conferences overseas, allowing the recipient to present high-quality research papers on an international platform. It is a wonderful opportunity for our doctors to gain exposure, share their work with wider audience, and bring back the insights that can benefit the clinical practice here at home. May I now request our chief guest Vidya Jyoti, Senior Professor Prasad Katulanda, to kindly present Anuradhapura Medical Association Travel Scholarship to this year's deserving recipient.
Ladies and gentlemen, it is now my privilege to present the Anuradhapura Medical Association Travel Scholarship for 2025. This year's recipient is a medical officer from the Department of Anesthesiology at the Teaching Hospital Anuradhapura. She represented us at the World Airway Management Meeting 2025 in Florence, Italy, presenting her article on airway decision-making challenges in a patient with mobile rhinosporidiosis flap in the larynx. May I now request Dr. M.A.F. Dinia to please come forward to the stage to receive the award. Ladies and gentlemen, let us congratulate her on this outstanding achievement.
Next, we take a great pride in presenting Anuradhapura Medical Association Gold Medal, awarded for the best overall performance in Final MBBS Examination 2025 of the Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. We are honored to invite our guest of honor, Dr. A.D.K.S.N. Yasavardhana, to present the prestigious medal.
This honor goes to the student who achieved 5 distinctions across all 5 subjects in her final MBBS, along with 4 gold medals for best performance in medicine, surgery, pediatrics, and psychiatry. Ladies and gentlemen, with a resounding applause, may I now invite Dr. R.M.M.P. Ratnayaka to receive the Anuradhapura Medical Association Gold Medal for the most outstanding performance in the final MBBS examination 2025 of the Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. Thank you, sir, for graciously awarding the medal. As we approach the conclusion of this wonderful evening, I would like to acknowledge that our program is nearing its end. To extend our gratitude to all who have contributed to the success of this evening, now I invite Dr. Vatsala Gunasekara, Joint Secretary of Anuradhapura Medical Association, to deliver the vote of thanks.
Good evening all. Chief guest Vidya Jyoti Professor Prasad Katulanda, Professor and Head Department of Clinical Medicine, Faculty of Medicine, University of Colombo, President, Ceylon College of Physicians, Honorary Consultant Endocrinologist. Guest of honor, Dr. Saman Yasavardhana, Senior Consultant ENT Surgeon, Lady Ridgeway Hospital for Children, Colombo. The orator, Professor Sisira Siribardhana, Chair Professor of Medicine and Honorary Senior Consultant Physician, Rajarata University of Sri Lanka. President of the Anuradhapura Medical Association, Dr. Priyangika Gamage, members of the Council, distinguished guests, ladies and gentlemen. Tonight's inauguration ceremony marks the beginning of the inaugural annual scientific sessions of Anuradhapura Medical Association. This grand occasion is the result of months of effort, dedication, and teamwork. At the outset, I wish to extend our deepest gratitude to our chief guest, Vidya Jyoti Professor Prasad Katulanda, for taking time out of your demanding schedule to grace this occasion. It is truly an honor to have a person of your esteemed stature as our chief guest tonight. We are equally grateful to our guest of honor, Dr. Samanya Asawardana, Senior Consultant ENT and Head and Neck Surgeon, for joining us this evening. Your presence too adds great value to this event. A special word of thanks goes to the distinguished invited foreign speakers from Australia and Greece who have graciously accepted our invitation to join the session. Your contributions enrich our academic program and help foster global collaboration. We also extend our deep appreciation to our local faculty for their invaluable contributions to the scientific sessions. Organizing an event of this magnitude is not an easy task, especially in challenging times. This feat was achieved under the remarkable leadership of our President, Dr. Priyangika Gamage, who, together with the Council, has elevated the Anuradhapura Medical Association to new heights. We also express our heartfelt gratitude to the advisors and members of the Council for their continued guidance and support. A special note of appreciation goes to Dr. Anuradha Jayatilaka, Dr. Visakha Kerna, Dr. Hemal Senanayaka, Dr. Chintaka De Silva, Dr. Tharanga Fernando, Dr. Dhammika Seneviratna, Dr. Vasana Mendis, Professor Anjana Silva, Professor Kosala Veerakon, and Dr. Prasanna Veeravansa for the untiring efforts put into making this event a resounding success. The support of the director, deputy director, and the consultants of the Teaching Hospital Anuradhapura and the Vice Chancellor of the University of Rajarata has been invaluable in leading up this event, and we are truly grateful for their assistance. The excellent work of Anuradhapura Medical Association office staff, Ms. Sashikala, and our team of demonstrators deserves special praise. A big thank to you all. Your dedication and efficiency have been instrumental in ensuring the success of this event. We also acknowledge the generous contributions from our sponsors in the pharmaceutical industry, which made this event possible. Your support underlines the importance of collaboration in advancing education and healthcare. A special thank goes to Dr. Sukita Gamage, our compeer this evening, who came all the way from Kurunegala despite her very busy schedule, and Dr. Nipun, who supported her in comparing today. Medical students from the Faculty of Medicine, Rajarata University of Sri Lanka, and consultants and ex-consultants from Teaching Hospital Anuradhapura for adding a touch of elegance today by providing us with excellent segment of entertainment. Mr. Kamal Disanayaka and his team from Global Events for coordinating this event successfully. Mr. Nishanta, banquet manager, and his team at Golden Mango Hotel for their outstanding services today. Finally, ladies and gentlemen, I extend my heartfelt thanks to each of you for being here with us today and for your unwavering support for the Anuradhapura Medical Association activities. Together with the Council, I warmly invite you to join us for cocktails and fellowship following the cultural show. Thank you and have a wonderful evening.
Thank you, Madam. Well, we have come to the end of today's academic proceedings. The stage is to be set for a brief session of entertainment. May I most respectfully request the dignitaries on stage to be seated in the audience. Thank you very much. Now, let me introduce the performers tonight. Our very own talented brothers and sisters of Faculty of Medicine, Rajarat University will perform for you. They will take you through a path of nostalgia, singing and playing some melodious singer favorites. The session starts off with a well-known song of old about the beauty and wealth of this historical city. It will sail through several harmonious classics, taking you through a rich variety of tune and rhythms. Ladies and gentlemen, please welcome on stage Aditya, Nadun, Nipuna, Malisha, Prasit, Malshani, Tarushi, Rashmi, Chamudita, Sandeepa, Chamidu, and Tarindu. Let's give them a big round of applause.
As in a baby, me
වසරක් ඈත අතීතයේ අනුරාධපුරය ඔබයි සිරිසර නිදහස් වසරක් ඈත අතීතයේ අනුරාධපුරය ඔබයි සිරිසර නිදහස් වසරක් ඈත අතීතයේ
It was a splendid performance indeed. Once again, ladies and gentlemen, let us give them a big round of applause. Well, with that, we close the proceedings tonight. Now, the ceremonial procession will leave the hall. Ladies and gentlemen, please be upstanding as the procession moves out. Thank you. I now gladly invite you to take part in the fellowship dinner and cocktail. Have a fabulous evening.